welcome to Medical Dialogues Journal Club, your daily dose of health and medical news. I am Dr. Nandita Mohan and I am going to talk about the recent European Society of Cardiology and the European Association for Cardio-Thoracic Surgery guidelines that have been published for the management of valvular heart diseases. Now, since this is a very vast topic, we are going to aim at aortic stenosis today. Aortic stenosis is a common valvular heart disease with an estimated overall prevalence of 3% in adults over 75 years. It is the most frequent single native left-sided valve disease comprising about 43%. Aortic stenosis is the most common primary valve lesion requiring surgery or transcatheter intervention, and its prevalence is rising rapidly as a consequence of the aging population. Now, the European Society of Cardiology, that is the ESC, and the European Association of Cardio-Thoracic Surgery Association have laid out a set of guidelines covering the evaluation parameters, the diagnostic workup, the indications for intervention, be it either TAVI or the surgical AVR procedure, and also covering the medical therapy. We have here with us today Dr. P Yadava, CEO and the Chief Cardiac Surgeon at the National Heart Institute, who will be briefly explaining these guidelines.
Good day, ladies and gentlemen. This is P Yadava from the National Heart Institute. Very recently, the European Society of Cardiology and Cardio-Thoracic Surgeons in the joint statement have released the guidelines for valvular heart disease. And we're going to address aortic stenosis today. The most important single investigation for aortic stenosis remains echocardiography. But before I talk of echocardiography, I must issue a caveat that for any investigation for aortic stenosis, we must make sure that the blood pressure is controlled, because if the patient has got uncontrolled hypertension, it adds afterload to the heart and therefore becomes a confounder which interferes with the assessment of aortic stenosis, which also increases the afterload of the heart. Now, echocardiography, as I said, is the most robust investigation, and we basically look at three parameters. One, the mean gradient across the valve. If it is more than 40 millimeters of mercury, it is called severe stenosis. Aortic valve area, if it is less than 1 centimeter square, and the velocity across the aortic valve, if it is more than 4 meters per second, then one would label it a severe aortic stenosis. But not always the matters are as crystal clear, and sometimes we have to resort in decision making to corroborative findings. For example, we may have to factor in the functional status of the patient. We may have to look at the degree of left ventricular hypertrophy, the left ventricular ejection fraction. We must also look at what are the comorbidities that the patient has, what is the natural history of the disease. Is it a bicuspid aortic valve? Is it a rheumatic valve? Is it a degenerative valve? And they have different natural histories. What is the longevity of the patient? You want to interfere in a patient and do intervention, then he must at least have a longevity of more than 1 year and must not be suffering from severe comorbid conditions which can curtail his lifespan. So that's also important. And lastly, the most important, what are the patient's preferences? This is very important that we factor in the patient, and that's why heart team consultation, in which not only the cardiologist and the cardiac surgeon, but also the family physician and the patient should be an equal partner in the decision making, is a class 1 indication of the new guidelines. Even after looking at it, there might be situations where the decision is very borderline, on very razor sharp thin edge. So in these patients, we may have to resort to further investigation. For example, global longitudinal strain may have to be looked at. stress echocardiography might have to be done. Sometimes we'll have to look at the degree of calcification on the CT scan, because if the calcification it's measured in the EACTS unit, and if it is more than 3,000 in men and more than 1,600 in women, well, it turns the decision more in favor of a severe aortic stenosis and towards intervention. And similarly, MRI may be required to look for myocardial fibrosis. So these are all corroborative investigations which may be required in an individual patient. After we investigate the patient, the type of aortic stenosis may come into various categories: a standard, gradient more than 40, valve area less than 1 centimeter square, and a valve velocity more than 4 meters per second. We'll call it a severe aortic stenosis. But then there may be a patient with left ventricular dysfunction, in heart failure, where there may be low flow, that is, the stroke volume indexed is less than 35 ml per meter squared. Now, in these patients, they may have severe stenosis, but the valve gradient may not be more than 40, because the heart does not generate sufficient strength to generate that kind of a pressure. So the debate then arises: is it a true aortic stenosis or is it a pseudo severe aortic stenosis? So in these patients, there is role for doing stress echocardiography or exercise testing, and we look at that if with exercise the patient gradient remains the same, the stroke volume increases, and the ejection fraction does not fall further, the aortic valve area increases, that means that the patient does not have severe true aortic stenosis. He is what we call pseudo aortic stenosis and has to be managed medically. To the flip side, if on stress echocardiography or on exercise we find that the blood pressure drops, the ejection fraction drops, the gradient increases, and the valve area does not change, that is reflective of a true aortic stenosis, and the patient is not able to generate pressure gradient because of LV dysfunction, and this patient may qualify for surgery. So it is very important to in borderline cases to do exercise testing. Exercise testing also helps in unmasking symptoms. A patient may be asymptomatic, but then he may be asymptomatic because he has curtailed his activities, and he may not be aware and may not be so much sensitive enough to pick up those subtle changes in his activities. So an exercise test, if an atrial fibrillation is provoked, pulmonary arterial hypertension takes place, or the blood pressure drops more than 20 millimeter, ejection fraction drops, or patient develops symptoms on exercise, then that patient would truly not be called asymptomatic and will be labeled symptomatic. Having said that, what are the indications for aortic surgery according to the new guidelines? No debate. If a patient with severe aortic stenosis is symptomatic or has got LV dysfunction, that's a class 1 indication for surgery. If the patient has got a low flow, low gradient, severe true aortic stenosis, and if the ejection fraction is low, that's a class 1 indication. But even if the ejection fraction is preserved, it's an indication for surgery, though a class lower, that is class 2A. But I must issue a caveat here that only if the patient's comorbidities are not severe enough, and if the patient has an expected life survival of more than 1 year, then we should proceed with intervention, because if the comorbidities are severe, life survival expected is less than 1 year, then it has been given class 3 indication, which in other words means a contraindication for intervention. Another important thing is, what do we do in true asymptomatic patients? Means we have made sure that they are asymptomatic even after doing an exercise testing. Well, if the patient with an asymptomatic aortic stenosis has low ejection fraction, has LV dysfunction, that's a class 1 indication for surgery. If the patient on exercise test gets a positive test, or the blood pressure drops more than 20 millimeters of mercury on exercise, then that's an indication for surgery. Also, these patients, which we know through the natural history of the disease that they don't do generally well, they have to be offered surgery. People with very severe aortic stenosis, which has been defined as a mean gradient of more than 60, and the velocity across the aortic valve of more than 5 meters per second. If the patient has got severe calcification, as I told you on the CT scan, or if the velocity is progressing at a very fast pace, you are doing serial echoes, and you find that the progression of the velocity of the aortic valve across the aortic valve is more than 0.3 meter per second per year, then these patients are a candidate for surgery. And if the patient is going in for any other form of a surgery, for example, he forms an indication for CABG, he has an indication for mitral valve surgery, even if he is asymptomatic, and he has got anything more than moderate aortic stenosis, they must be offered surgery. Now, that's the guidelines as it stands today. But over the last 6 months, a lot of work has been done on asymptomatic aortic stenosis. In fact, in JAMA Cardiology, Gahal et al. Published the meta-analysis of 29 studies looking at the natural history of asymptomatic aortic stenosis, and they found that they have a mortality of almost 5% per year, 4.8% to be precise. They have cardiac mortality of 3% per year, sudden death of 1%. Now that's not a big number, but and we feel that it has been overspoken and over-exaggerated, but still it's a number. And these patients, almost 18%, develop an indication for aortic valve intervention over the next 1 year. So these patients, according to Gahal et al., are better served, even if they are asymptomatic, with early surgery rather than watchful waiting. And the mortality hazard ratio, if you went in for early surgery, was 0.38, means almost 60% reduction in mortality with early surgery. The same was shown by the recovery trial, and very recently, just a couple of weeks back, we had the AVATAR trial, which was a multi-center trial, and in a 32 months follow-up, it was found that the primary composite endpoint, which included mortality and heart failure, occurred in 15% of patients who went in for early surgery, and it occurred in almost 35% or 34.7% of patients who had watchful waiting. So all this evidence today is driving us towards early surgery in asymptomatic aortic stenosis if the surgical expertise is available. And I think next time round, we should see a change in the guidelines. And lastly, I would like to talk about the debate between the TAVI, that is the percutaneous aortic valve implantation, versus the surgical aortic valve implantation. See, everyone knows that in extreme high-risk cases, TAVI was shown to be superior to surgical AVR. In high-risk cases, it was non-inferior. And in low-risk cases, according to the Partner 3 trial and the Evolute low-risk trial, it was non-inferior. But the guidelines, they are very practical. They talk of that we must look at the longevity of the patient also, because through the TAVI, we place a biological valve which is expected to have a survival of around 15 years or maybe even up to 18 years, the current generation. So we have to look at the expected survival or longevity of the patient. We also have to look at the paying capacity of the individual, because TAVI is 4 times, 5 times costlier than the surgical AVR. So science must address the aspirations of the society. So the guidelines today say that if the patient is elderly, more than 75 years, he is a high-risk candidate for surgical AVR, and he is a fit candidate for a transfemoral TAVI. Only transfemoral, that's a class 1 indication for TAVI. On the flip side of the coin, if the patient has a low surgical risk, a predicted surgical mortality according to the STS or the Euroscore less than 4%, if the patient is relatively younger, the European guidelines say 75 years. I suppose in India, our survival is little less than the Western world, so we can even take a lower cutoff at around 70 years or even 65 years. And if the patient is a high-risk case for TAVI and is not suitable for transfemoral TAVI, then that would form an indication, a class 1 indication for surgical AVR. But these decisions have to be taken in a heart team, realizing that TAVI has a problem of higher incidence of paravalvular leak, higher incidence of permanent pacemaker implantation and conduction abnormalities, and higher vascular complications. But there is a countervailing higher bleeding risk with surgery, higher incidence of acute kidney injury, and higher incidence of new onset atrial fibrillation with surgery. So they have to be balanced, and decision has to be taken considering all these facts. Lastly, a couple of special subsets have been talked of in the guidelines. One is women. They are very high risk as compared to men. They are high risk. So they should be offered, surgical, the indication should be at par with the men, but generally we ignore them. And if the patient with aortic stenosis has associated coronary artery disease, then that's a bad prognostic sign, and these patients must be taken care of more aggressively. One must also realize that as aortic stenosis increases the afterload, mitral regurgitation gets overestimated. So when we look at concomitant lesion and estimate them, we must factor this element also. So these are some of the important findings of the new guidelines, and essentially the driving thing is we must involve the treating family physician and the patient in the entire decision-making process. Thank you very much.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.